Good morning, everyone. We're going to start. I'm going to introduce our speaker today. Echo here. But before I introduce the speaker, let's introduce the introducer. My name is Florian Baida. I'm a professor of biostatistics at UCSD. I've worked in HIV for a very long time, 25 plus years, and I'm a long-term collaborator with our neighbors here, HVRC. It's my pleasure to introduce our speaker today, Dr. Claire Davies. She is visiting from the University of Stellenbosch in South Africa. She attended the CROI conference in San Francisco and agreed to come down for a visit at UCSD for a week. Claire and I have collaborated for a number of years now, as she completed her PhD thesis in epidemiology and biostatistics, and she has other collaborators here at UCSD, including Dr. Sarah Brown, which I believe I saw on Zoom, but I might be wrong about that. So Claire, please go ahead. She has worked with a very interesting cohort of children with HIV in South Africa. It's a well-established cohort that was followed longitudinally. Now they're all adolescents, I believe, and she's going to present some interesting results from longitudinal analyses of this study, looking at especially at inflammatory markers in this group.
Great. So thank you very much, everyone, for having me in San Diego. It's lovely. I'm sure, I hope the weather will improve over the next few days so I can see some of the sites. I'd just like to acknowledge, thank you very much, Professor Bader, as well as Professor Brown, as well as my South African colleagues who have been running the trial and started seeing these kids from birth. So yeah, we've got a few. And so like Professor Bader mentioned, I'm looking at non-communicable diseases in early treated children living with perinatal HIV infection in South Africa. So just also to begin, I'd just like to acknowledge my funding. So Specialists in Global Health, who've been funding my postdoctoral fellowship, as well as the NIH Fogarty and the National Research Foundation of South Africa. So we all know that HIV infection is associated with non-communicable diseases, including insulin resistance and metabolic syndrome, cardiovascular risk, pulmonary disease, and neurocognitive impairments. And this is partially driven by ART, as well as the virus itself, and co-infections such as hepatitis C. Now, all of these diseases start in childhood. So for a child being perinatally infected with HIV, they will have lifelong exposure and potentially increased risk to non-communicable diseases. Now, sorry, I think my heading was a bit cut off. Now, whenever we talk about children with HIV, it's very important to assess the timing of ART initiation. So before 2008, the WHO, sorry,
no, just that OK button. The comments say that you can see the headers.
Yeah, I think it just, the font, when I've moved PowerPoint version.
No, it's visible.
Okay, yeah. Yeah, so before 2008, the WHO recommended delaying ART in children until they had advanced HIV disease. And this was owing to potential long-term toxicity from the drugs. We've got potentially limited availability of drugs in resource-limited settings, such as ourselves, potential ART resistance as well. And so that's why they actually said, well, you know, they set thresholds for CD4 count before you started your ART. Then the SURE trial came in, and that was actually conducted at our site in Cape Town. And it was a 3-arm trial where we had firstly children that were put on ARTs directly after birth. And then we had a delayed treatment arm as well. And we had an interrupted treatment arm where that started and then interrupted a year later. And that trial showed that those in the early treatment arm had a 3 times lower mortality than those in the delayed treatment arm. And actually the trial had to be stopped early for ethical reasons, and all children were therefore put on ART straight away. And subsequently now the WHO changed their guidelines, so now all children are initiated on ART straight after birth, regardless of your CD4 count or any clinical signs of HIV disease. And so we have been following up these children, and must I go closer? Thanks. So we have been following up these children now their entire lives. So it's an amazing cohort because it started off as this trial and they've been uniquely cared for now. And now they're all adolescents, they're kind of reaching 16, 17 years old. And they've just had this excellent care throughout their lives. They've been virally suppressed. We've got over 90% viral suppression in our cohort. We've also included some children from the P1060 trial. I don't know if you know the Impact Network. And they were also at our study site, started ART early as well. And so, yeah, it's a very unique cohort, first in the world to start ART shortly after birth. So now as they grow up and we have a look at some of their markers, it's almost a predictor of what will happen to other children that are now receiving ART directly after birth. As I said, they received excellent clinical care. The moms love it because the child gets a cough and they can phone the pediatrician and come for free straight away, which is unheard of in our setting. And they've avoided the consequences of a delayed ART start. So they haven't experienced those co-infections. They haven't had the cumulative organ damage from the repeated co-infections. However, they do have cumulative ART exposure, and they will have for the rest of their lives. So it's also assessing, well, what impact will this cumulative ART exposure have, kind of 40, 50 years down the line? We don't know. Maybe they've got increased likelihood of heart attacks and strokes. So we have a total of 485 children, 141 living with HIV. We also have 2 control groups. So 169 are exposed uninfected, and those are through the prevention of mother-to-child transmission programs. And we've got 175 unexposed, uninfected. And these children, they come from the same socioeconomic background. So a lot of the times, the unexposed, uninfected children, they're cousins, they're friends from the same school, who were involved in this trial at the same time. And they also quite like it because they can also just phone the doctor and come whenever they're sick. So we believe that it's very important to study the long-term profile of these children, as it will represent the next generation of early treated children living with HIV. And what we also believe is that the drivers are probably different. So the current studies on children that started ART late, a lot of their non-communicable disease risks are raised, but the drivers for our children are very different because they don't have those co-infections, they don't have, the cumulative organ damage prior to ART initiation. So our objectives, firstly, was to understand the longitudinal progression of our non-communicable diseases in our early treated children, and we compared them to the 2 groups, to the exposed as well as the unexposed. And there we looked at 5 different areas. So we looked at insulin resistance and dyslipidemia, cardiovascular disease, pulmonary disease, neurocognitive impairment, as well as liver disease. So we tried to cover a broad range. And the second objective was to understand the underlying immune mechanisms. And there we looked at a number of different inflammatory biomarkers, hoping to understand why do these children have increased non-communicable disease risk, and potentially understanding a mechanism so that we can stop it in future and start, intervening at this earlier stage. So these were our baseline characteristics. So infected, they're slightly younger, but most children were in Tanner stages 1 and 2 when they enrolled in this second longitudinal study. But obviously it's longitudinal. And then they were all on older regimens. So it was lopinavir, ritonavir, or efavirenz. And in terms of our methods, so we use linear mixed effects models, to evaluate the trajectory, and we controlled for confounding variables. Any child who had at least one measurement over the time period was included. Some of the children had up to 6 measurements, which gave us really good longitudinal follow-up data. The median was 3 measurements per child in this sub-study. So we used a directed acyclic graph just to understand the confounders. So in a lot of studies, we found that people adjusted for BMI in their study. But in our study, looking at, if you're using metabolic indicators in outcome, BMI is actually a strong, it's on the causal pathway. So we had to assess very carefully which variables were either confounders or on the causal pathway. So now the results, right? So we used HOMA, which is the homeostatic model assessment of insulin resistance, and we also looked at android fat mass, which is a measure of fat distribution around the chest and abdomen area. We also looked at triglyceride to HDL ratio and LDL cholesterol. So in terms of insulin resistance, so the blue line is actually the infected children, and we found that it was raised up until about age 10. But thereafter, it resolved with time. And this might be a pubertal effect, that kind of puberty comes in, everything goes a bit haywire. And so, the insulin resistance therefore normalized and went more in line with the uninfected group. We did notice that both the triglyceride to HDL and the LDL cholesterol were significantly elevated throughout the time period. So there you can see that blue line is much higher. Which means that we still need to monitor them for insulin resistance and dyslipidemia, as well as some subclinical cardiovascular disease. So there are some warning signs. It's positive, but some warning signs as well. Then we looked at cardiovascular disease, and here we looked at pulse wave velocity. Now, pulse wave velocity, it's a ratio of the distance between the carotid and femoral arteries divided by the transit time. And it's actually the non-invasive gold standard measurement of arterial stiffness. And obviously with kids, we can't do anything invasive, so we have to find the most acceptable measurement for these young children. Pulse wave velocity is highly associated with the degree of atherosclerosis, so it's a good measure. And actually what we found is that the lines were very similar. There was no significant difference between our infected group and both the exposed and the unexposed. So we concluded that excellent adherence, a consistent viral suppression, and early ART initiation may protect against cardiovascular disease, which is really positive considering all the other studies of children starting ART later in life indicated increased cardiovascular disease, increased bacterial disease. Then we also looked at the pulmonary disease. So we looked at a range of measures. So we had spirometry, plethysmography, diffusing capacity. And in spirometry, looked at forced FEV1, which is forced expiratory volume in 1 second. We also looked at forced vital capacity and the ratio of the two. And again, there, not much difference, as you can see, between the 3 lines, which was also really positive because compared to other studies, our children starting ART earlier in life demonstrates much better lung function measures compared to previous studies, which showed diminished childhood spirometry. However, one thing we did notice, so when we looked at residual volume, which is the amount remaining after maximal exhalation, the residual volume was greater. It's kind of, it's a p-value of 0.04, so it's somewhat borderline, but it is still greater in the infected children compared to the uninfected and unexposed. And this may indicate some air trapping, some subtle signs of small airway disease, and we'll just have to monitor this going forward. So it just gives us an indication that we can't just look at spirometry for the children, but we actually need to look at plethysmography and diffusing capacity as well. Interestingly enough, all these lines have got a downward trajectory. And so we used the Global Lung Function Initiative to create Z-scores. We used the other category because there's not really a category for Africans. But it just indicates that it doesn't apply in our situation to use these global lung function standards. Sorry, if anybody has any questions, feel free to just raise your hand and chime in.
Yeah, I was just thinking on the graphic where you show the differences between cholesterol among the three groups, triglycerides. Obviously, there is a higher level on the infected patients, but there is no correlation with cardiovascular risk, so it doesn't make sense.
Well, it's probably a timing thing.
Okay,
So, you know, the pulse rate velocity was taken at the same time. So maybe by the time that they reach 20s, we'll start seeing that in the audience.
okay.
Dr. Davies, I saw someone put something in the chat. I don't know if anyone said anything online.
How do I do that?
Do you want to ask if anyone online said something? Just ask.
So, sorry, are there any questions online?
Oh, no worries. We were just having some difficulty with seeing the slides, but we're good.
Okay. Yeah, but feel free just to raise your hand. I'm quite happy to take questions as we go along. It's probably a bit easier sometimes as well. Is it all okay?
Can you click one more time on the slide?
In terms of neurocognitive impairment, a colleague of mine, Kaylee, she looked at this and she found that in terms of executive function, at both ages 7 and 9, the infected children had slightly lower metrics than the uninfected and unexposed. And this was largely around semantic fluency and auditory working memory. So it's just something that we need to be aware of. In terms of motor dexterity, the children living with HIV, they performed worse at age 7, but this actually by age 9 had resolved. So it's positive that they are showing some signs of cognitive recovery. And then in terms of visual spatial processing and problem solving, our children living with HIV, again, they showed a significant significant improvement between ages 7 and 9. Again, positive, showing that there is cognitive recovery. And finally, we looked at liver disease. So CAP is its controlled attenuation parameter, which is a measure of hepatic steatosis. And we also looked at liver stiffness. And this study, I don't know if you know, you can see it's ages 12 to 18. So one of my colleagues, Dr. Penny Rose, she collected the data at a later stage when the children were starting to transition to dolutegravir. And it was quite an interesting time to see the effects both before and after the transition. So here the groups are actually slightly different. We compared the unexposed to the children on older drugs, which is the red line, and the children on the newer drugs, so dolutegravir. And there you can see, so for CAP, children on the older drugs had a much greater CAP than those on dolutegravir and those that are unexposed. However, liver stiffness didn't actually change that much over the time period. So it's positive that switching to dolutegravir reduces your controlled attenuation parameter. But in terms of liver stiffness, actually perhaps starting ART early may protect them from developing hepatic fibrosis. So again, it's a good sign, and it's further great that now switching to the newer regimens, we are seeing some of these side effects going away. So in terms of the public health implications, so our cohort is great because we believe that it provides a unique picture of the future of children living with perinatal HIV infection. Obviously, it's great that HOMA resolves with time, and the pulse rate velocity is not that much different, and some of the spirometry measures as well. But we still need to keep track of the elevated triglyceride to HDL ratio and LDL cholesterol, as well as we should do additional lung function tests, including plethysmography and multiple breath washout and forced oscillation. Now I'm just going to go through the second objective, so looking at the immune markers to potentially understand the inflammatory profile of our infected children compared to the uninfected. And this study, also the sub-study taken over the same time period. So we're actually still busy with objective 2. So I'll show you what we've done so far, but we're hoping to continue and keep analyzing the data. So again, children now aged 7 to 16. So we started that when we looked at this, we decided to just focus on those that had started really, really early. So it had to be within 3 months of birth. And we compared it to the unexposed, uninfected. And we looked at 26 inflammatory proteins. So it's across a range of so we had monocyte-derived biomarkers, lymphocyte response markers, some metabolic, and some cardiovascular markers. So it was a full range using Luminex. And what we found is that, so after, doing our linear mixed models, and then we still adjusted for multiple comparisons, we still found that soluble CD14 was MCP1, IL-6, VEGF, CRP, and adiponectin were raised in the early treated children compared to the unexposed, indicating that there is some underlying monocyte activation, and markers associated with cardiometabolic disease. Now, interestingly, adiponectin is actually based on the research, it's meant to be the other way around. But our cohort, with greater adiponectin in the uninfected. But our cohort is quite unique in that our infected children tend to be very lean. So compared to the uninfected, who have greater BMI and greater weight, infected they're termed unhealthy lean. So the relationship between adiponectin and your BMI, that is why adiponectin is raised. We also just took all the infected children, and we wanted to identify which ones are more at risk. So which ones have high inflammation, which ones have lower inflammation. So we did a principal component analysis, and then we did k-means clustering, and actually they clustered really, really well. So you can see here the high is the orange and the low is the green. And across all the myeloid, lymphoid, response markers, metabolic, cardiovascular markers, the high inflammation were high across all of them. And likewise, the low were low across all of them. And so within early treated children, there's the subgroup of very high inflammation, and another group which are actually kind of fine. They're equivalent to their uninfected peers. And when we looked at the underlying characteristics of both the high inflammation and the low inflammation group, so the high inflammation, they're slightly younger, about 1.5 years less in age, and so they're correspondingly they weigh a bit less. That would make sense, but interestingly, the age at which they initiated ART, or the CD4 count, or the viral load, that doesn't make a difference. But in our cohort, the cotinine is a measure of secondhand smoke exposure. And so our high inflammation group, the main reason why it is because they had greater exposure to secondhand smoke. And it doesn't happen so often here, but in South Africa, when you go into pediatric hospital, you have to first go through the plume of smoke, because everybody's smoking outside, and then you can get into the hospital. And so parents also, they smoke at home, they're cold, and we don't have heating like here, so you close all the windows and doors, and the children are just exposed to a lot more secondhand smoke. So yeah, that was actually interesting, because it's something that the doctors can do about. We can encourage the moms to stop smoking, and it's a great intervention. So in terms of future plans, our cohort reveals valuable information on the next generation of early treated children living with HIV. We're hoping to combine the inflammatory marker profiles with the non-communicable disease indicators, and kind of assessing the underlying drivers in early treated children living with HIV. And ultimately, we'd love to identify mechanisms for the increased risk of non-communicable diseases in these children, so that we can start intervening at a much earlier age. Now, actually, I was chatting to Florent earlier. I don't know if everybody's aware of what's happening in South Africa at the moment with the pullout of the funding. So a lot of our HIV clinics are closing. So maybe this won't represent the next, maybe our next generation of treatment, the children won't have access, maybe the moms won't go on PMTCT. So yeah, so it's, current situation aside, let's hope that this is the next generation, but you know, we also have to take cognizance of the fact that a lot of our funding has been pulled, so the clinics are closing. Yeah, so if anybody has any.
On that note, thank you very much. Any questions?
Yeah, I don't know if you mentioned at the beginning, what are the plans for your cohort as far as how long you'll follow them?
So they are now kind of, 16 to 20 years old. And so obviously now with the switch to adult care, it's a little bit complicated, but we are trying to keep them in the hope of a cure. So that's kind of what we're saying to them is stay, because maybe in 5 to 10 years time, there might be a cure. And then at least as a trial cohort, you'll be the first, you'll be there. So yeah, we're trying as much as possible to avoid the transition to the adult care.
Wondered with the exposure to secondhand smoke, did you see any interaction with their HIV status, or was the effect of that, the association with inflammation pretty much the same across the groups?
It was the same across the groups, actually, so.
But you do have that information for the uninfected, you do have these measurements for the uninfected.
Yeah, we do have it for the uninfected.
It's, yeah, it's an interesting finding, and it suggests that they might be more sensitive to perhaps to smoking.
Perhaps
So
to smoke exposure.
I don't know if
Yeah.
you've actually looked at this association and whether it's stronger among the HIV infected.
Yeah. Yeah, that's true, because actually all the previous analyses that I showed, we adjusted for cotinine in the hope to just assess the underlying drivers. But the last one, because we were just looking at the infected group, that's where the smoke exposure, but yes, thank you, I need to look at that as well.
Yeah, and one other question, because you talked about adjusting for various confounders with looking at triglycerides and so forth. Did you adjust for or look at nutrition or food access?
So we didn't have that much. So nutrition is such a difficult one. So somebody in our group, and a dietitian, she did surveys, but we haven't managed to translate it and integrate it into the study yet. I mean, it's something that we'd love to do, but I think, you know, when you look at these 140 surveys and across carbohydrates and proteins and everything, we actually haven't. But yes, it could be a confounder, because the mums could be, I mean, it's almost reversed, because what happens is mums tend to treat the infected children better in our situation. So they're like, oh, my, you know, say if the one child was infected and the second child they had the MTCD, so it was fine. They often look after that infected child, make sure they have better nutrition, make sure they have, you know, let's look after them a lot better.
But they're still leaner.
But they're still leaner.
Yeah.
That's right.
Okay.
Dr. Blanchard asked, was adherence among the kids, and was there a dip with adolescents?
Well, no. So adherence was fine, because they are followed up so closely, and they have been used to going to clinic every 3 months since birth. So our adherence is, you know, pretty much 100%. Every time that we noticed a slight dip in viral suppression, it was come back to clinic. We're going to see you now weekly. We're going to make sure that you get back up to speed. So, you know, it wasn't kind of, we'll see you, you know, in a year's time. So it was good. What happens sometimes with our control groups is, because they're healthy, they sometimes, oh, mom, I don't want to go to clinic today, kind of thing. I'm feeling fine. Why can't I go to school? So sometimes our control groups, you know, either they were lost and then we'd have to chase them up again, say, please come back, you'll get free lunch, you'll get free transport, you know. So it was actually more of an effort with the control groups than with the infected group.
That's actually quite different than our experience here. That sometimes for the little kids, well, for any age, it just kind of depends on the family situation. But yeah, adherence can be difficult despite close follow-up. And then we have observed a dip in adherence frequently at adolescents. So congratulations on a more compliant population.
Yeah, what we're running now with the adolescents is they've moved into groups. So we, especially sexual education groups, counseling groups, just so that they can manage this transition to becoming adolescent and being, you know, almost HIV positive whilst you're going through this transition. So we found group work is actually very beneficial.
Yeah, we have support groups too, but I think, you know, there's just a lot of rebellion at having been made to take these meds forever and their whole lives. And yeah, so again, well done.
I just had a quick question. Are you looking at substance use disorder or alcohol abuse with the population now that they're getting older? Is there any plans for that? Because I know there's an increase in South Africa at this time, especially in Cape Town.
Yeah. So now as they're getting older, we do need to start looking at that. Our cohort, fortunately, there wasn't, you know, even as kids, so substance abuse is a problem for us as well as kids, even just with glue. But fortunately, that wasn't an issue. But now alcohol abuse might start coming into play. So we do need to start looking at that.
Sarah Brown has a question. Sarah?
Hi, thanks for this great presentation. Could you indicate, are all your children now on a dolutegravir-based regimen? Were they all transferred over? What was the ART exposure?
Yeah, I believe all of them have transferred now to dolutegravir.
Okay, because it should be interesting to follow over time in terms of
Yeah, so we've done that already with the liver data where we compared before and after, but we can still now do it with the other data. It's all dependent on if we've got the money to collect the data.
Yeah, no, I understand, but duration of exposure, I'm not sure the duration of exposure was that long. With the initial...
dolutegravir was only, just kind of 2022, the switch over. So we'll still have to keep following them up.
Then as a follow-up, could sort of what some of the other questions people have raised, you know, what Gigi pointed out. What do you have any indication about stigma? Stigma is something that people discuss a lot, and as children become more aware, they enter adolescence. Are you collecting any data on that?
So I must actually chat to some of the psychologists. They might be collecting data on stigma. To be honest, I'm not sure. Stigma is an issue in South Africa, but I mean, a large proportion of our population is HIV positive. So perhaps it's slightly less of an issue than here. I'm not too sure. I'll have to speak to you.
Because it was interesting, you know, what you're talking about, the cataclysmic effects of stopping PEPFAR in its tracks. I mean, absolute cataclysm. I mean, this is absolutely unbelievable. I think it's beyond everyone's imagination that anyone could ever have conceived of doing this. But one of the things that was interesting of the adults that were talking about this situation at the CROI meeting was that part of it was people didn't want to go to the regular pharmacy, because when they stood in line for the regular pharmacy, there was a lot of open discussion or loud discussion. There was no privacy, and they were then concerned about showing up and picking up antiretrovirals. So to hear the stigmas operating at that level was remarkable, to be honest. So it just does seem to be something that's even a player in the background in South Africa, where you've had so much effort to talk about HIV and so much effort to get so many people on drugs, that this was a theme that I think I had 3 times raised with the impact of the PEPFAR funding.
Yeah. We don't notice the stigma so much with our children because they get their drugs from the hospital. But I think it's more in the men who have sex with men. There is a lot of stigma about that in South Africa. And all their clinics have been forced to close as well. So I think particularly for that group now, going to a pharmacy, oh, you're HIV positive, oh, now, you know, therefore you're in this category. And I think that's where a lot of the stigma comes in as well.
Yeah, that's true. And then the people that were talking about this actually at Croy were women. And they were exactly what you raised, that the difference between going to the setting that PEPFAR had funded and the open pharmacy, where people are, you know, tens of people standing in line at the same time and no privacy or no, it was interesting to hear that. I think this is really, the stigma is still such a big thing. But thank you. This is extraordinary work, very complicated work, because you have to do so many controls and control for so many confounders, and following a cohort over a long period of time, and this incredible moving into adolescence when we know there's a lot of change in the immune system, and then pushing towards adulthood, and the degree of exposure that these kids have had to ARVs, clearly a very unique cohort. And I hope that we find ways for you to continue your work.
Yeah, I just want to echo Sarah's comment. It's such interesting work, and obviously I've been involved in much of this myself. But to see it put in this wider perspective here, where everything is gathered together, there's this picture that emerges. So it's you know, you were in a unique situation given your training, given your setting, to do all this and bring it together, and it's fantastic. One comment about adherence in adolescence. I remember that I have a paper, I think in 2007, with Aki Saito, who was an investigator here at UCSD, and he did a retrospective study looking at adolescents who interrupted their ART treatment, and not surprisingly, we found that their markers went down. So the CD4 percentage was one of the primary markers we looked at, and we could see that decline, and ultimately forcing them to go back on treatment because the doctors got worried about that. I have a couple questions. One has to do with those lipid markers where you saw higher levels among the infected kids, the triglycerides and LDL. I couldn't recognize the units of measure. I don't know if you did the analysis on the log scale. So do you have a...
Converted them back. I did do the analysis on the log scale, but I think they were converted back.
So do you have a sense of the effect size, if that's concerning or not?
I think it was concerning. I can look at that. Yeah, that is something.
And then secondly, there's this sort of common feature that we see the infected kids at the age of 8 or 9 doing worse, but then catching up, right? So it was in a couple of markers. So is this a sign of delayed adolescence? Is this something that that we saw? I don't remember if we looked at the Tanner stage, how that changes over time, if there's again delay, there's some sort of delay among these children.
Yeah, so we did look at Tanner stage, and we adjusted. So we adjusted for Tanner stage to try and take out the effect.
Looking at Tanner stage as an outcome in terms of seeing whether
we haven't actually done that. I mean, there probably is some delayed puberty. I can,
that could explain some of these aspects that we've seen across, quite disparate markers, right? With the infected kids looking worse when they come in, and then catching up. It's like, okay, that's fine later on.
Although even adjusting for that didn't make a difference, we still saw that effect. So, but yeah, it's something we can look at.
Yeah, going back to the lipids, did the results on the lipids, cholesterol justify treatment? Were these patients on treatment?
For the metformin or something?
Yeah, the studies, because that may correlate with lower inflammation markers.
So it didn't justify it enough to put
them on what's below this question?
Yeah.
Oh.
Is it because they're children, or even in adults who wouldn't put them on statins?
I don't know about the adult population, but in children, yeah, we decided not to.
Like, never heard of children on statins.
Yeah. And we didn't know what would happen, over puberty, so we kind of didn't know.
Were other other infectious diseases like congenital or acquired CMV or malaria, for example, comparable across the groups? And did you see any
So,
effects of that on inflammation?
yeah, so fortunately no malaria in our area. Nobody had CMV. We had, was one or two who might have had TB, but we excluded those. So fortunately, we didn't have that many co-infections. And
No, that's fantastic about the CMV.
yeah.
Any other questions online?
Great. Well, thank you very much. It's been a pleasure.
Bravo, well done.